Well, the anesthetic protocol we use when we use the LOA is a different setup than people are used to seeing. Traditionally, an anesthesiologist is standing behind the patient, and as the patient goes to sleep, they're using a mask ventilation. And once they're completely, or mask oxygenation, and once they're completely asleep with the anesthetic, they put this very large tube with this big donut looking thing on the end of it, and they just have to kind of shove it and push it from the top side and spin it and mess around till they sort of feel like they think it's popped in the right position. And then they'll connect it to something big, an anesthetic machine, a circuit, all these types of things. Kind of cumbersome, relatively expensive, large equipment to have in an office-based setting. And then it'll work more like a traditional general anesthesia. For the LOA, you'll actually stand right next to the patient and you'll have them open their mouth.
Give me a big ah, wider if you don't mind, a little wider. Thank you.
And you have an oxygen cannula in their nose and they're just breathing oxygen in and out. You put a little gentle pressure on their tongue base, and then as the anesthetic goes on board, and we typically use a relatively large initial bolus of propofol, 180 or so, you'll feel the floor of their mouth give way, and then you'll pop the LOA in position. It slides in easily, it's not difficult to get in at all, and you immediately move the oxygen cannula from their nose directly into the notch of the LOA, and crank up the oxygen delivery 5 liters or so in the back, and you're good to go. That's all that's needed for the entire case.
You can always just see at induction that their eyes begin to get a little vertical nystagmus, a dazed and confused look, and I can actually feel their tongue base giving way, and that's just when I insert the airway in.
No anesthetic machine, no circuit, no fiddling with trying to get the airway in position.
Moving the oxygen cannula from their nose to their mouth is easy because the LOA itself has a specific notch that the nasal cannula fits perfectly in. That means it won't move during the case. It means it's also got a tight seal, and that will deliver the oxygen really well in a closed channel directly to an area right above the vocal cords themselves. And then of course it's closed channel on the opposite side for the capnography to be measured as well. So we'll get really good oxygen delivery, excellent capnography, similar to what you'd get when you're using an LMA, but since the device itself is not in contact with the laryngeal surface, it requires way less anesthetic. So she got a nice good bolus of propofol, and she'll go through a period of apnea probably. But with the airway in place, the saturations will typically maintain beautifully. And if there's any desaturation, it also recovers very quickly. If for any reason you needed to bag them because their apneic drive lasted longer, the airway is beautiful for that. Keeps the airway nice and open, makes that bagging very easily until you move their saturations back up again, and then you can just have them breathe spontaneously for the rest of the case.
And obviously, much easier also in reverse at the end of the case.
Can you open your mouth real wide for me? Say ah. Open real big. There you go. All finished. I'm just in recovery right now.
If the patient's breathing well, you can easily remove it, or even if they wake up and they have it in their mouth, it doesn't bother them, and you can easily remove it at that point.